So Fright 2, this is our group was looking at the challenges of adopting AI into NHS practice, and we started off by talking about access to data. In fact, we spent quite a lot of the session talking about data in various forms, but access to data is clearly still a big problem for companies and for researchers hoping to develop AI solutions, and obviously without any AI solutions there will be no adoption. So sorting the data problem out is quite key. And we then started to discuss more widely about the problems of adopting not just AI but actually anything into the NHS at all, really. Existing care pathways are set, difficult to change. And any sort of change in of those pathways is fraught with difficulties, funding difficulties, organisational difficulties, difficulty getting people to adopt it. Early adopters come along, but can you get everyone else to do it? And often there's some rivalry. It wasn't invented here, it can't be any good, especially if it's invented in Oxford. Cambridge won't use it, and so on and so forth. So there are, and I think we all recognise that actually, that changing anything in the NHS can be enormously difficult. So I asked the question, let's look at an example of a success where something really changed everything, and we kicked a few ideas around and came up with something called heart flow. I know nothing about it. I'm a pathologist. It's obviously upstream of where the patients come to me. But heart flow apparently is a very successful change in cardiology, which is non-invasive, it's cheaper than surgery, and it's just as good. And why wouldn't you do it? So we went through the pathway. 2016, there was good clinical trial data evidence. 2017, NICE approved it. In 2018, there's NHS funding available for this. And this is seen as a success story, and probably is. HeartFlow has $500 million behind it, so a substantial amount of funding still needed to get even something that's clearly in everyone's interest to get into practice. A lot of money is still required to make things really happen. So just put that thought with you. Next problem we looked at was specific issues around AI. And we talked quite a bit about standards, DICOM standards, implementation into the workflow. If it's not in the workflow, it's not going to be used. Interoperability, both between different AI between different platforms. Will it work on Roche platforms as opposed to Siemens, etc., and so on? And if it does that, will it work between different populations, different centres, or even different populations across the world? So all of that needs challenges really which are specific to AI. And then there's the problem about scalability, how you take a proposal which is working well and scale it up across a large area, and that's an enormous challenge that's faced. We talked a bit about how difficult it is for SMEs just to sell stuff generally to the NHS. They're not necessarily part of a framework. I didn't quite understand what that meant really, but if you are buying big chunks of kit, you have to be part of a framework agreement, and that usually means established companies, not SMEs. Is that going to change? Well, possibly. Supply Chain Coordination Limited apparently is going to change that. And make the landscape more fertile, I suppose, for SMEs to grow. And then we thought a little bit about the NHS, and just we all think it's this enormous, fantastic organisation which has enormous resources of data, extremely valuable market, and so on. Actually, only about 3% of the global market. So if you're really selling something, actually the NHS is not necessarily your first port of call in any case. Much more attractive would be the US or China, where, generally speaking, hospitals are much more flexible in their approach to taking on new things. Obviously, there are important differences, social differences between ourselves and China in particular, which make life, which is important to take note of. But nevertheless, these are the competitors that are on the global scale we need to work with. Let's move on. We talked a lot about data, as I mentioned, and mentioned the Sensine data access in Oxford. Apparently there are 9 different models of how to share data. We're not sure which is the most successful one. I don't think anybody is. Clearly there's a lot of concern about the ethics of using patient data. Patients vary from thinking you're already using it and why shouldn't you be to make my care safer and better, that's what they expect to happen, to the why are you using my data and making money out of it without telling me or asking my permission. So those issues need to be taken care of and understood and catered for in the way that we handle patients' data and use it and exploit it, particularly for commercial gain. We talked quite a bit about the 100,000 Genome Project and the difficulty there is in accessing the gel data that's come from that and the lessons which need to be learned around that. But it turns out we have a number of data repositories in the NHS. You won't be surprised by that, I'm sure, but you may be surprised by the sheer number of them. Apparently St Thomas's has 373 different data sources in the hospital, and other trusts have up to 400 different data systems as well. So enormous variety of legacy systems which contain patients' data. And if it's going to be of any use, of course, we need to bring that all together into one usable form, which is what is expected from NHSX. Special measures, IT staff of variable quality. These are pressures which face many trusts across the country. And clearly, if you're in special measures, adopting innovative technology may not be at the top of your list. And finally, there's the quality of leadership in our trusts and how they respond to what's coming in the form of AI. Are they really capable of understanding what it can deliver for them? Well, we have an answer. What it can deliver for them is to organise your back office. So another example from St Thomas's and King's. Reorganisation of the back office, meaning that you get your data into a usable format. You can start to look at who's non-attending clinics, and you look at the postcodes, where these people come from. You understand who they are. You connect that with the weather forecasts, and you can predict who's not going to turn up and improve your throughput by 5%, which is millions of pounds saved in the health service. So that's how you can do it. And it's got nothing to do with AI interpreting images. It's all to do with getting your data in a usable form so you can analyse it and make sense of it. Okay.
So our group discussed at length and debated on the educational needs of healthcare workforce related to AI. First of all, whether there was a need. Yes, there is a need. We've heard eloquent lectures throughout the day about how it improves efficiency, quality of healthcare systems. But the main crux of our discussion was, who do we educate? Who does the education, and what tools do we use to educate people? For the need to educate, there is a variable need across the workforce, and the definition of workforce has changed from the traditional definition to include a much wider scope of people: the clinicians, the operational people, the admin staff, the IT, industry, and the pool which is provided by the patients and the public. So there is a clinician need for trust, safety, efficiency, but there is the need to understand the language of AI by the admin staff, the operational staff, the IT sector of industry, as well as academia and the NHS. So what do we teach? How is this approach? How are we going to approach this? Is it just going to be a basic taught program? Is it going to be something intuitive? Means when we think about mobile phones and how people learn to use mobile phones, they just play around with it, and that's how they get used to it. So is there an element of intuition in learning about AI? So the conclusions that we reached was that the initiative has to be coming from multiple organizations. So it has to be coming from the clinicians, from the industry, and from the academia, because without industry explaining the language of AI to the clinicians, to academia, and clinicians and academics placing them therefore in a context, we do not get the full value out of this system. And these initiatives might lead to something like an AI UK, a group which could be easily be formed, or an NHSX, which could lead in delivering these initiatives. But we cannot forget that there are end users, such as the patient and public groups, who are an important component of the workforce today, and they drive our research and our innovation through patient and public involvement. When we go about doing this teaching, so we have to think about that we are teaching the basic language, the ABCs of the language. And it is an element of taking the fear out of the unknown. And this is not just a fear of the mistakes that can creep in with AI, but just a fear of being not familiar with the language. There are socio-cultural fears as well we have to address, that AI assists, it does not replace, because there might be a considerable portion of the workforce who might think that, will AI lead to a job loss for me? There can be age concerns that people who are of the older spectrum, they might not be so familiar with the language that is being used. But at the same time, we have to impress upon them about the improvement that it's going to come. And it will free up time. You will perhaps get more time for patient contact because AI will assist you and will help you get you some free time. So the best way to do this is to come to good leadership qualities, and you will always have enthusiasts in your department, the unsures and the skeptics. And the enthusiasts will always take up these leadership roles in whatever aspect they are, from the industry, from academia, and from the clinical side of things. And they can build little workshops in their own departments. They can build online educational tools. For example, I said in Nottingham, we are setting up some CPD modules on digital pathology, etc., to go out to industry. So this is a cross-way talk between industry and academia, because they also need to understand what context we are looking down at these slides. And similarly for radiology or for any other medical discipline, people need to understand the context each one is, so that there is a crossover of the language that we speak in. So a good thing to do would be doing some basic transforming the landscape events, which you can hold locally and then emerge it out to networks, and then nationally, and then internationally through conferences. You could start with some simple approaches, like having an app developed, which you could have an NHS app. So anyone who walks into an NHS institution, just as they get their basic induction training, they can use this for training delivery and have a basic training about what AI means. And this is across the NHS, not directed to a particular group. So this is a pan-NHS initiative. And how to use with the patient. So for clinicians, it might mean what to do about the limits, what to do about the flaws, the risks, the ethics. So all these are built in, just as we learn a bit about ethics, a bit about data confidentiality, etc., in basic induction programs. A bit of AI can be set into that context. So it is a baseline literacy program which we should be aiming for, and which should separate out the hype, the claims that, oh, so AI will cure this and this 100%, and you won't require to see a doctor ever again. So take out the hype of these statements and just come back to the commonalities that you share with other streams. And One of my colleagues from Oxford, she eloquently said that when we look at new blood tests, etc., we tend to believe them. We don't go too much into the nitty-gritty of them. As long as it is evidence-based, we know how it works, and we can explain to the patient in a very basic language how it works. That is fine. We don't need to understand the complex mathematics that has gone into it. So there are commonalities with other streams, such as the multi-omics, the genomics, the metabolomics, etc. So this will be an AI-omics sort of things, which will stream in. And just as you've got educational programs coming in for the other streams, there will be an educational program for AI. But what was stressed, that the teaching is not just from the clinical side or the industry side, making us understand the language of AI, but also us academics and clinicians teaching the industry of the context. So that is very important. But there are issues, the funding for the teaching. So there can be funding issues, there can be time issues for teaching, which needs to be considered. And I think for that, the enthusiasts always find a way to deliver teaching, perhaps to small groups. And if you teach one, that other person goes on and teaches one more. For data access, I think digital innovation hubs and the HDR will lead educational programs across the country. And Innovate UK can lead on educating once all these different centres which are leading on the AI-related bids in different radiology, pathology, etc., they can come together. The data analysis centres that are already existent in the country, I think they can all come together under one umbrella and deliver some teaching together. And we've had a day of fantastic teaching here today of people who've been here from various disciplines, and we've learned from each other. And I think that just shows the way forward. Thank you.
Okay, so our breakout discussed gaps and challenges really for integrated diagnostics, and we covered some of the same ground as the first group in particular. So we began by considering the gap around the source data, the data that we're using to build AI tools, and the need for, as a first step, better standardization of source data. It was noted even in imaging, for example, there are huge variations in data types and file types. So as a precursor, there's a need for a quality control element before algorithms are even brought into the equation. Alongside that, we need good quality, diverse training data. There is a need for an access to more diverse cohorts, possibly partnerships with international partners, and we discussed different methods that might be adopted, perhaps some forms of distributed learning in multiple locations using data from each place. But there are challenges about how you bring that together at the end and demonstrate the quality of the tool you've developed. We noted, of course, that the NHS is sat on a pile of data, huge, massive historic data. But in our discussion, we wondered whether we would get best value from going back through that mountain of data and annotating, curating that data, or if perhaps an alternative is focused on what we have now and what we can produce going forward in terms of high quality, well-curated data sets. And we concluded, obviously, there probably is a role for both. In the end, when we discussed what we would do perhaps with a big pot of money, it was agreed that investing a sum like 100 million in annotating, curating historic data would be highly valuable. There's obviously the problem of certain data sets that may be high quality, but may not be suitable for extrapolation to real-world examples as well. Then we discussed the kind of quality standards we're expecting from AI tools and the kind of sense that we are expecting them to produce results that are above the current human standard of care. And we discussed whether that's an acceptable approach, and And we concluded there may be a kind of two-lane concept where we have a slow lane of short to medium-term AI development, which allows us to develop tools that are up within the general human standard of care, but perhaps we need to be viewing a long-term slow lane development which produces AI that exceeds those standards in the future. We also talked about the value proposition of AI and how it's currently valued within the system. Is it currently properly valued within procurement? Well, there was the sense that return on investment calculation is currently too narrow. We're not incorporating social care costs within the equation, and procurers are focused on their own narrower budgets. So we're not getting a true value for some of the benefits of these tools. There's a kind of a range of cultural gaps, challenges, barriers that we discussed as well. Obviously, the workforce aspect is a major issue here, as these tools are hugely disruptive potentially. And we noted there is obviously, a political element to innovating in the care system. But there was also a public engagement issue here, and we were challenged by the best approach in terms of engaging the public. We questioned whether it's ethical to actually go down the path of selling AI tools to the public to say, here are the benefits, it could be better for you. So I think then there is a need for work to deal with that. Then we discussed the challenge of developing tools that are tackling our greatest priorities, and the challenge of developing tools to deal with those who have multi-morbidities, the complexity of trying to develop trials and the evidence of those sorts of cohorts, and the sense that there are a number of sort of low-hanging fruit that has encouraged competition amongst multiple developers producing algorithms of similar quality based on the fact that they have access to good and relatively easy data sources. So it was noted that there's a lot of focus on lung and breast cancer, for example, but maybe less focus on some of the harder to address cancers. And it was felt there was probably a role for someone to stimulate activity for those harder to address problems. And when we came to the kind of the money question, as I said earlier, we discussed where money would be best spent if you had a large lump sum, and we considered that probably curating historic data would be valuable. We also felt there were other market issues. So, for example, the place of SMEs in the landscape, how they don't necessarily have the ability to access funds and break down doors themselves. It was noted that it's extremely challenging for SMEs to go and speak to hospitals, to go and put their proposition to them, whereas major industry players may not find it so difficult. So we felt there is a role for some sort of brokering in that process to encourage SMEs. Perhaps larger industry players help with that as well. But the role of the SME is important. They're producing algorithms that the big players may find takes too long and too difficult to produce. Thank you.
So obviously from an Innovate UK perspective,